Okay, so I've got the task today to spend about the next 40 minutes or so talking about regular health assessments for young people with Rett syndrome. I always flash up a slide with my disclosures. None of which I think are particularly pertinent to the meeting today, but just to say I've done some consultancy work for Neurology in Acadia, and I'm the PI for the TASIA study, as has been already introduced. So I think if we're going to talk about Rett syndrome, I think we should talk a little bit about Andreas Rett. So Rett syndrome was originally described and recognised in the 1960s by this fantastic paediatric neurologist there. And we now know it's one of the commonest genetic causes of learning difficulties in females. Definitions of Rett syndrome have changed over time. The last diagnostic criteria in 2010, and I think they're overdue a bit of a revision now. And whilst there's a really strong association with changes in the MECP2 gene, it remains a clinical diagnosis. I think Andreas Rett was a pretty inspirational man, actually. He's very sadly no longer with us. I didn't get the opportunity to meet him here. But he was born into quite a well-to-do family. And he actually got disowned by his father for pursuing a career in medicine. So I think that's a pretty sort of dedicated way to start your life and career. I've put here that he built a factory for disabled youngsters to work in. Some audiences have interpreted that I was saying he was some kind of slum mobster who got children to do his work there. But the point was, he was someone who very early on was very engaged with the participation of young people and adults with disabilities in normal living activities. And that was advanced and ahead of its time there. So he's a very, very good man. And as I said, he really came up with the first description of Rett syndrome in 1966. I absolutely love this quote from him. "Their eyes are telling me something, I just don't know what it is." And I don't know anybody who spent any time with young people with Rett syndrome who wouldn't reflect on this and recognise that this is what it's like with these young people, isn't it? So I've said that Rett syndrome is a clinical diagnosis, so what do I mean by that? So to have a diagnosis of Rett syndrome, you have to have a period of regression in your development, followed by then a period of stabilisation. It's not a progressive, ongoing degenerative syndrome. There are 4 major criteria. You have to have a loss of hand skills, a loss of speech, the development of very characteristic hand stereotypies, then you go on to have problems with gait, either unable to walk or an abnormality of your walking. There are a list of 11 minor criteria. Some of these are very specific to Rett syndrome, some of these are quite generic for neurodevelopmental disorders. And then importantly, you've got some exclusion criteria, particularly that period of abnormal development in the first 6 months of life there. And to have a diagnosis of what we call typical or classical Rett syndrome, you have to have all 4 of those major criteria and none of the exclusion criteria. To have a diagnosis of atypical Rett syndrome, you have to have at least 2 of the major criteria and then 5 out of the 11 minor criteria there. And you're allowed to have those exclusion problems if you have that diagnosis of atypical Rett syndrome. Now, think about how this relates to the MECP2 gene. We'll hear about this a lot as the day goes through when we talk about our advanced therapies. But if you have a diagnosis of typical Rett syndrome, about 95 to 98% of young people then are going to have a change in that gene. When it comes to atypical Rett syndrome, it's about 75 to 80%, and there's a large number of genes that have been associated with atypical Rett syndrome. Some of them sit in that MECP2 pathway, some of them are quite distinct to that, and I think it's been the observation of lots of us working in the field for a while that some young people who have a diagnosis of atypical Rett syndrome early on, over time their clinical picture can change and it can look something different to Rett syndrome. So that's a group without the MECP2 mutation we need to follow up on quite closely. My personal opinion, I think that actually that divide into typical and atypical is a little bit artificial. And I think really what we've got is a severity, a spectrum of severity from the less severe to the more severe. And at that more severe end, you tend to accumulate symptoms. So those young people who've got more intrusive epilepsy tend to have more intrusive movement disorders, tend to have more of the GI problems and more of the respiratory problems there. And I think it's going to be interesting, given how much more accessible genetic testing is now, and that's informed our understanding of the phenotype, the next generation of clinical criteria, I think, are going to be quite significantly different. But watch this space. Thinking then around that MECP2 gene, so really, if you have a problem in the gene where you don't make enough of the protein, that gives you that clinical picture of Rett syndrome. And these are going to be young people and adults who are typically female. They usually have a normal early development before the regression. Regression is really universal for the criteria. They often have a risk of seizures, and they can have multiple seizure types. We know they have problems with development, and speech development is very uncommon. On the flip side of this, if you have too much of the MECP2 gene, then you end up with a different clinical picture, that MECP2 duplication syndrome. And these are young people who are typically male. They typically have very early delayed development. They don't go through a period of regression. very often have seizures, and it's usually generalized tonic-clonics. And the only real ever difference between Rett syndrome there is that there's a suspicion that they have a problem with their immune system, but that's still under evaluation. And nowadays, we tend to, as clinicians and geneticists and scientists, group these all together as what we call MECP2-related disorders. I think it's important for us not to forget males. This is a small but important group of individuals there, and how the MECP2 gene changes affect them is different. So if we're thinking about our chromosomes, we get half our chromosomes from our mum, half our chromosome from our dad, and if we've got two X chromosomes, that makes us female. If you've got an X and a Y chromosome, that makes us male. Now, I've said this before, the X chromosome is a powerful chromosome, and actually you need to turn one of them off if you've got two in your cells there. Oh, I'm just getting a bit of feedback. And depending upon how much of the bad gene or the bad chromosome compared to the good chromosome is turned off, that is going to influence whether you have a milder or a more severe phenotype for your for Rett syndrome. Oh, sorry guys. So if you're a male, you've only got one X chromosome, you've only got a bad copy of the MECP2 gene, and so you tend to get a much more severe and much more intrusive phenotype. So what are the main priorities for individuals with Rett syndrome when they come to clinic? So this is data from my own clinic. This is a little bit of a busy slide, but essentially as we go from left to right, we see that there is less of an intrusive problem. So this is just screening questions. So see the commonest things where we see very often there are problems. It's with communication, teeth grinding, problems with walking, spasms and other movements, dribbling, hand biting, all the way through to the right-hand side of that slide there when we're talking about problems with scoliosis and hip dislocation and joints there. Now, of course, there's a bias to this because I'm a neurologist, so the type of individuals and young people that come to my clinic tend to have more of the neurological problems. You're not going to come and see me if your main problem is a scoliosis surgery. I'll have a go, but I won't do a very good job of the surgery there, so you need proper professionals to do that. When we ask people what their main reasons, so what do you want us to focus on, this is what we find out their priorities. The biggest priority, and I think this holds true in any kind of analysis of what parents and families' priorities and needs are, it's around improving communication. I think that's important because when we're talking about clinical trials, this is a really important endpoint for us if we're going to make sure that what we're doing and the changes we make to young people are meaningful. Problems then with abnormal movement, mobility, feeding, sleep disturbances, and then interesting epilepsy is kind of at the end of that list there, so it's less of a priority for the young people I see. And I suspect that's because it's generally managed quite well in other settings. So if you look around the room, you will realise we are not all the same. Okay, the children I see in the clinic, the children that I see, these beautiful young people who are around the room, they're not all the same. And actually, their problems, their challenges, their priorities are all going to be very different there. And so I think it's important when we're talking about checklists, when we're talking about things that we recommend you ask about, you've got to make sure that you're focusing on what's the priority for you. So my advice for any family that are going to any appointment, why are you there today? What do you want to get out of the appointment? And make sure that there's an opportunity for you to express that. Because if you spend 30, 40, 50 minutes speaking to a doctor and you don't address your priority, it's been a complete waste of your time. And I think it's really important to say, I am here today because I want to sort out X, Y, and Z. And I love it if people do that in my clinics because it means I can focus on that and I know I'm going to do the best job I can in that all too limited time I have with young people. So if we're thinking then about how there are differences in the priorities and the needs for young people, the stage of Rett syndrome, I think, is quite an important way to look at this. So many of you, but perhaps not all of you, will be aware of this staging. We talk about the first stage of Rett syndrome, where we have that early stagnation of the development, then going into the second stage, which is the period of regression. The third stage then is this pseudostationary, or the plateau stage, where the young people have stopped progressing, and there's a potential for them then to go on and gain developmental skills. And then at the end there, oh, press the wrong way, we've got the fourth stage there, this period of motor deterioration where we accumulate more secondary disability, more problems with our chest and the like. And I think really, really importantly, this is not inevitable for young people. It's not inevitable that young girls with Rett syndrome will go into stage 4. And I firmly believe that with good interventions, with good therapy, with a mindset that this is not a progressive and degenerative condition, we can prolong that stage 3 for our young people for a much longer period of time there. There are some young children who progress, and we need to be aware of that, but it's not an inevitability for everyone. Now, we need to talk a little bit about life expectancy. I know this is not an upbeat slide to talk about, but it is in a way. This is what we call Kaplan-Meier charts. It's essentially looking at the estimated survival of young people with Rett syndrome, and this is data that's been taken from the natural history study. Now, the important thing here, and I'm not sure I can project it across everyone, but if you look at the 80% survival, that's at 50 years of age. So nowadays, we're expecting that 80% of young people who are diagnosed with Rett syndrome will live into their 50s and beyond. And that's a mindset we need to make sure all clinicians have. This is not a disorder of childhood, this is a lifelong condition, and we should be planning for young people to be transitioning to adulthood and having a long and fulfilling adult life there. And that's a really important message that we as a clinical community need to make sure all of our colleagues are prepared for. Symptoms change over time. And this again is data taken from the natural history study in North America. The left is epilepsy, and essentially the bars that aren't green are where young people are having epilepsy. Each bar is at a different sort of age there. So it's under 4 to 6, up to kind of 26 years and older. And there's a similar bar on the right-hand side looking at breathing problems. And you can see there's this hump here, isn't there? So problems with the breathing, problems with seizures emerge and are more frequent for the first decade of life, and then they tend to settle and stabilize. So the medical needs, the symptom needs of young people will change over time as a natural part of the evolution of the condition. And then if we look at it in a very simple way, the spectrum of young people we see from those who are non-ambulant, who are wheelchair bound and have a lot of physical needs for their mobility, compared to those who are ambulant and independent they're walking, the kind of health needs and the kind of interventions that they need at different times are going to be very different. Other side of this is I'm a neurologist, so I tend to think about everything from the neck up, but there's quite a lot of important things that happen from the neck down in our young people with Rett syndrome there. And whilst we do tend to think of it as a neurodevelopmental disorder, it's a multi-system disorder. And we know that all of these different systems, not for everyone, but for lots of young people, and this changes over time. I'm sure if I was to kind of take a spot survey of the families in the room and say, how bad's constipation now? And then come back in 3 weeks, and then come back in another 3 weeks, that'll go up and down. And if I say, well, what about reflux? That'll go up and down as well. And sometimes it'll go up and down together. Sometimes it will change over time there. And so what we need is a way of tracking these kind of symptoms in multi-dimensions over time. And we might need different kinds of specialty doctors to step in at different points when there are different types of symptoms that are more pressing and more concerning there. So what we need are groups of doctors, not just neurologists and psychiatrists and developmental paediatricians, and adult doctors as well, of course, in each of these different specialties who have an understanding of the condition and the kind of problems that arise with it. So if we summarize that kind of bit of the talk quite simply then, the health needs for individuals with Rett syndrome are going to differ by the age of the child, by the stage of their Rett syndrome, by their functional ability, and by their comorbidities. So any kind of checklist is going to be a general starting point. We really need to personalize it to the wonderful young people that we're seeing in this room. And it's lovely. It's a beautiful cacophony of sounds from up here, actually. It's lovely to hear people happy in the room there. So do we know how to manage all the symptoms of Rett syndrome? Okay. It might shock you to hear us admit we don't know. Okay. So really importantly, this is a domain where there is not anywhere near the level of evidence that we need. And that's really important for us because what we're going to try and do is give our best opinions and consensus, but we need to work collaboratively about this and not be too dogmatic about the things that we can't state as fact at the moment. When we're looking in medicine around what we call quality of evidence and the quality of our guidance, we have this ascending sort of chain of evidence that you can see here. So it starts with what we call case reports. So this happened to this child when I gave them this drug, and so we think we should try it again. Cohort studies where we look at larger groups of people and give them an intervention. Then up to randomized controlled trials where we give half the children one thing, half the children a placebo or another drug and compare them. And then when we get enough evidence, we can put it all together. And the more evidence we have, the better we can be in terms of how secure that we know that our guidance is right there. But at the minute, if I put it here, we're at that point where really what we've got is opinions from experts. And I don't describe myself an expert. I'm an enthusiast in Rett syndrome there, because experts sounds too clever and too grown up. But also what we've got is a consensus. So people that see a lot of young people with Rett syndrome have come together and they agree that we think that this is the right thing to do. And this is the kind of advice that we can offer and pass on to other clinical teams. In terms of sources for this, there's a couple of things I'll point you towards. And I should have said I'm very happy that we'll circulate the kind of PDF of my slides so that you don't need to kind of make any kind of notes of the references there. But John's already mentioned the Rett Syndrome Health Checklist. Those are a couple of years back, a consensus guidelines on managing Rett syndrome, very importantly across the lifespan. This is not a disorder of solely childhood there. And I think these are a really good resource for us to start those conversations with our colleagues who are seeing children with Rett syndrome to guide those appointments. So looking at how they split up young people across the lifespan, that guidance from the international expert group looks at different stages or different ages. So they talk about thinking around what happens in the first 5 years of life. So when diagnosis has been made, when you're at a point where you're seeing most of the symptoms like epilepsy and movement disorders and breathing problems emerging, problems with feeding and emerge at that side if they are, and you've got the tail end of the regression going into that plateau period. And this is a time where people are getting used to this diagnosis, they're finding out about it there. We then move on to about 5 years to just before puberty there. What you find is your developmental features stabilize, so you're not going through the regression. You start to have the potential to gain those skills there. Starting then to get problems with your back, with your hips potentially if you're not mobile there, problems where you need to be very actively monitored by our allied health professionals. Children who've often had very low tone and been quite floppy as infants then often develop higher tone, spasticity and dystonia that I see. And then you have all the horrible problems of puberty. And I've already disclosed I've got a 13-year-old girl in the house, so you don't need to tell me about the horrors of puberty. We then have that early adulthood or late adolescence there. And actually what you find is when children stop growing, the risks of problems with their bones and skeletal development start to reduce there. So that you've got the amount of scoliosis you're going to have there. But what you start to have are problems with adult health. And this is where people like myself who are pediatricians get a bit hopeless, because I get really scared by adults there, and because I don't really know about adult health issues that like blood pressure. I know it's something we need to monitor, but there's lots of things that just because you've got Rett syndrome, it doesn't protect you from other common conditions. So we need that expertise. And then we've got that later adulthood there from 21 years up there. And what you're saying is that clinically things tend to stabilize, but you start to, over time, potentially get that slow loss of mobility. And the other big issues you get there are about your bone density. So because bone density is reduced, the risk you have there is increased risks of fractures and those kind of problems there. So different points in the lifespan, different priorities, different issues, different groups of clinicians and social care professionals that we need to help there. It's a lifespan condition. So we're going to go through a bit of a checklist, and as I say, we'll circulate the slides there. And we can think about it looking at these different kind of areas, these different domains, these different systems. I think it's important to think though then, so what doctors screen for what symptoms? And I think this is a bit of an opaque area. So one of my priorities, and I know speaking to the other clinicians in the room we agree, is to try and get a better kind of pathways and clearer pathways for how young people are looked after. If we think, and this is a very UK and paediatric sort of centric approach here, but we tend to think about primary care as that first level of care. So it's the GP, really hugely important part of your care, particularly as you go into adult life there. And then any points of contact you have with the emergency department. Secondary care in paediatrics is your general paediatrician that works at a district general hospital. And then you're very importantly a community paediatrician who'll work in the local community health centre. And then you've got the more tertiary care, the teaching hospitals, what I call the ologists. So I'm a neurologist, but we've got endocrinologists, we've got neurologists and the like. And then on top of that, we've got what we call the quaternary care, so the really super specialist clinics. So I'm a tertiary care specialist for neurology, but aspects of what I do are quaternary care. I take referrals from around the country for Rett syndrome, for movement disorders. Professor Santosh's team would fit into this as well there. And it's kind of working out where is the care best delivered, how do we get people between these levels in an efficient way when they need to be accessed and need to be seen. As a principle, I think very firmly, as much care as possible should be delivered as close to home as possible. And so what I think we need is networks for advice and support, rather than a pilgrimage of families down to a small number of centres that takes hours to get to there. And this is what we want to build up there. Now, the problem in the adult world is we don't have that secondary care. There's no equivalent of a general paediatrician for adults. There's no equivalent of a community paediatrician. And a lot of that overseeing and pulling together role needs then to come from the primary care. So become friends with your GP, okay? Children with chronic and adults with chronic diseases are allowed to have an annual health check. I think that starts from about 16, but people will stop me if I've got that wrong. Start to have those conversations and start to meet your GP. If the first time your GP meets your complex young person is when they're 18 or 19 years of age in the middle of something going wrong, it's not going to be the best experience for everyone. But if you meet them for that annual health check when things are calm, when things are collected, you can start to have that relationship. They'll start to recognize, oh, I need to find out about Rett syndrome and I need to learn about it. So court that relationship as early as you can. They're a hugely important part of everyone's care. There are ologists, but at the moment there's not Rett specialists, a very limited number of Rett specialists. Professor Bank obviously is a geneticist who spans between paediatric and adult care there, but I think all of us would recognise that this is an area where we need to build specialties and experience in the UK. So this might be the most important thing I say. What's most important is what's most important to you. So whatever I might tell you about the things I recommend you consider or ask about when you're going to appointments goes back to why you're there, what's the problem, and what do you want that clinician to help you with. And that's the most important thing. And if that doesn't get addressed, that appointment's not been the best use of anyone's time. So then thinking through then the advice and the general assessments. So we're thinking around then the genetic side. This is really at the start of this journey when the diagnosis is first made. So everybody, when a diagnosis is made and that MECP2 mutation or other gene is found, should have the opportunity to discuss that with a geneticist, should have the opportunity to discuss it with a genetic counsellor, and really importantly, get a copy of the results for your own files there. It's amazing how often things get lost in the system. And electronic systems are a bit better now, but I've got lots of young people where it's not clear where the testing's been. It's really hard to find it. It's likely for some interventions moving forward, the specifics of the change in the gene are going to be important. So it's very empowering for you guys to have that kind of copy and that information there. Every 6 to 12 months, someone needs to be keeping check on obviously medications there, and the general assessments that we need to be doing at 6 to 12 months are around weight. We're terrible at this. We know if your young person is in a wheelchair when they come to clinic and they need to be hoisted into a scale, chances that they'll get weighed are much lower than for an ambulant child. And that's not right. We need accurate weights. When your weight is going up, when your weight is going down, it has a big impact on your general health. It has a big impact on dosage of medication. So we need to make sure that children with Rett syndrome who are non-ambulant are getting properly weighed at least twice a year, if not more frequently there. And then of course we've got things like the head circumference, Tanner staging for puberty. So both delayed and early puberty are common in young people with Rett syndrome, and if you're not monitoring for that, you're not going to pick it up. The question often comes up around how important is the genetic change in terms of what it says about the future for my child. And if we look at the very group level, there are some changes, some genetic spelling mistakes that are associated with a more severe picture, but at the individual patient level, it's very, very, very variable. I'm not someone as a clinician that puts a lot of purport on the genetic change in terms of predicting the future for young people. But again, I think it's an important thing that people are aware of. And I know that Professor Santosh, I think, will touch upon this in some of the talk they're talking about modifiers for phenotype, which is some really exciting and interesting work that's coming through the service. Okay, gastrointestinal nutrition. I would like to see in the future the amount of time you guys have to listen to neurologists in these meetings go down, and the amount of times you get the opportunity to speak to gastrointestinal doctors going up, because I think the gut is much more important in many ways than what I do there. I spend a lot of time talking about poo in my clinics, and it's such an important part of what we are faced on a daily basis. So we need to be reviewing feeding methods, appetite, problems with chewing, inability, choking, the length of time with feeding. We need to be actively screening for gastroesophageal reflux, and we know that has a really big impact on quality of life. Problems with gas bloating, issues with the bile ducts and the like, and then importantly constipation. We also need to be carefully thinking about nutrition, having access to dietitians when appropriate there, and it may be appropriate to consider nutritional buds periodically. Respiratory and cardiology, hugely important as well. The lungs and hearts are quite important organ systems, as you can imagine there. So what we need to be doing in our appointments every 6 to 12 months is screening to see if we're getting problems with our breathing and trying to kind of phenotype that a little bit. It's hard, but are the issues with hyperventilation? Are the issues with breath holding? How we might treat those differs, so it's important to get that kind of character there. Look for problems with the air swallowing, screening for recurrent problems with respiratory tract infections, because there's things we can do about that. If you're having lots of respiratory tract infections, is it because of problems with saliva control? Do we need to reduce the saliva? Does your child need to go on a prophylactic antibiotic to reduce the chances of them having those chest infections? These are important things to screen for, and we can improve health moving forward. And then, of course, for the cardiology side, at the very least, we need to have that yearly ECG, so looking for the long QT interval. And this is just what it looks like there. Essentially, these are the different phases of the cardiac cycle. We've got the P wave, the QRS, spiky bit, and then that long T wave there. And you can see when you've got the long QT, essentially that tail end is dragged out there. It's very rare that that in and of itself is a problem for our young people, but there are medications that we commonly use that can prolong that, they can make it worse. And if we make it too long, there's a risk of arrhythmias and other problems coming out. So we need to screen for this. It's a simple, non-painful test, at least every 12 months. Okay, neurology. Of course, I'm going to talk about neurology, and I'll try and rattle through some of this because people have heard me talk about it a lot before. So very importantly, we need to screen for what we call paroxysmal events. So things that come and go unpredictably. And we know that there is a lifetime prevalence of epilepsy of 70 to 80% in our young people, but lots of things they do are not seizures, and it's important to be critical about that. I'm going to show some videos and have a few slides about that there. We need to look at anti-epileptic medications, and really importantly, going back to that weight issue, if weight's fluctuating up and down too much, we might need to reduce some of those medications or increase them. This is why it's important to track that very accurately there. Then, of course, what we want to do is to screen for any problems of abnormal movements, and then importantly, the impact that has. If a child has some high tone or has some unusual movements, if it doesn't cause a problem, it's not a problem. But if it's causing pain or distress, if it's getting in the way of dressing, if it's getting in the way of cares, that's something that we might need to treat there. So I'm going to go on a little bit of a tangent about Rett episodes, if you'll tolerate that and indulge me for that there. So if we think about paroxysmal events that might look a bit like a seizure, but aren't a seizure, there are lots of different ones. If we think about behavioral things, we can have sudden changes in mood and emotional dysregulation. There's behavioral disturbances, a huge hope of sleep disturbances, parasomnias and the like. Neurologically, we've got lots of different movement disorders, and I'll show you some videos of that there. And then with our respiratory, we've got periods of hyperventilation, the apneas or breath holding, shallow breathing and the like there. And as I say, this doesn't project quite as well. I can see some people are squinting, so sorry about that, but we'll circulate the slides, don't worry there. Okay. So this is a young lady with Rett syndrome who's having a seizure. Now, if we pause, it will start. Is that playing? Right. When you play videos, there's a sense of relief that comes through the body as a presenter when it actually starts to work there. Because the rule is, if it doesn't work, you have to act it out, which is often quite embarrassing and not very dignified there. But here we can see a young lady with Rett syndrome who's having a focal seizure. There's been an abrupt change in behaviour. There's thick staring of the eyes. There's an unresponsiveness. And then the early stage, there's some rhythmic movement of the jaw there. Okay? Comes to an end and we're responsive again. I'm going to play that again, if I can. Okay, is that going to play? So eye deviation, the tensing of the arm. Can you see the little bit of movement of the arm there, that quite rhythmic movement? So this is a focal epileptic seizure, quite a common episode and event that we see in our young people. There are lots of things that aren't seizures though. So let's see if this plays again. So here we can see not unconscious. So this young lady is awake, doesn't look very happy. This is not a pleasant experience. We've got a change in breathing, we've got some stiffening, and there's a shaking there. Not that nice rhythmic jerking, it's a shaking, a tremulous movement there. Okay? A very common type of paroxysmal event, and I would describe this as a paroxysmal tremor. Is it an autonomic episode? I think we don't quite have the nomenclature for that. And these are really common. The other video is also an event. Oh, okay, oh, can I do that? Turn it down. Oh. Okay, oh, sorry guys. But again, not very happy, obviously not a pleasant event, bit of stiffening, the tremulousness, some autonomic activation. I can understand why people would worry about a seizure, but it's not a seizure event there. Other events that we have, oh, is this an event? Oh, sorry, I'm pressing the wrong bit there. Oh. Other events and other types of episode of movement disorder. So here we can see rather than tremulous shakiness, we've got wriggly, writhey movements. Again, we're alert, we're responsive. Doesn't look particularly happy, this young lady, so it's obviously not that comfortable. And this is an episode of careerful movement disorder. And then just to play the other video, we can see a similar careerful movement. So 3 different types of neurological paroxysmal episodes. They look different when you watch these kind of things often enough. And important to differentiate because we treat them in very different ways, different medications and different interventions. So that leads me on to this question as, is there such a thing as a Rett episode? Can I check, has anybody been told their child has Rett episodes? I'm getting some nods and some hands going up there, okay. So there are 2, or at least papers that I found that have given definitions for this, and the problem is they're very different, okay? So one definition talks about non-epileptic vacant spells describing a variety of other features which might also be seen including motor activity, for example, twitching, jerking, head turning, falling forward, trembling, autonomic changes, and you've got to love a definition where you have to stop and take a breath in as you're saying the sentence there. It just trips off the tongue there, but then the automatic changes and behavioural signs there. So that's everything, isn't it? That's a bucket list of all the different things we can do. Some movement going up, some movement going down, breathing going up or breathing going down. Then another way of looking at it is a simpler definition. Non-epileptic behaviour, often misidentified as a seizure, which the eye gaze is not fixed, the person appears to be not breathing, and there's an absence of movements here. So this term's used, but it's used very variably. And the question I've got is whether, is there a core of an event that's a unique type of thing that young people with Rett syndrome do? And I think EBAD, that Professor Santosh is going to talk about, can explain some of that. Or are these completely different things? And actually, do we need to tease them all out completely separately to be able to get to the right treatment? Oh. And this is just looking at it kind of diagrammatically there. But again, this is just for your benefit, we'll circulate there. But separate streams or a kind of combined stream for that there. Okay. So moving on to thinking about skin and bones. So again, really important. We need to be thinking about the temperature, colour of the hands and feet there, screening for problems with the skin breaking down from hand mouthing, or really importantly, badly fitted splints and braces. If a splint is causing problems, it's not a good splint and it needs to be changed there. Looking at the back, looking at whether there's a change in the scoliosis over time there, and looking at the hips and looking at other joints. Now, we talk about the scoliosis, and we talk about the angle of the curvature, and this is what we're talking about in the diagram there. So you're basically taking lines from the top vertebra that's bending and the bottom of the bottom vertebra that's bending, and you're measuring the angle there. And there's a critical angle over which most orthopedic surgeons would think it's about right to intervene. Timing of that's really variable. We want young people to have gone through as much skeletal maturity as we can, but we need to think about what the impact is and how quickly it's bending. No one wants to have a big surgery unless it's needed, but I very strongly believe that scoliosis surgery is the right thing for most of our young people with Rett syndrome, and it's about doing it at the right time when things haven't curved so far that you're not going to get the best outcome afterwards. That balancing act between leaving skeletal maturity, but then not letting the curve go too far. Oh, I'm going the wrong way again. When we talk about hips, this is just an X-ray on the right side. The hip is nicely in the socket, and on the left side, it's slipped out quite a long way. Now, for the adults in the room, if our hips suddenly moved out like that, we'd be in excruciating pain, we wouldn't be able to walk, and we'd be rushed into hospital. But when this happens slowly over time in an immature hip, it's surprising that it often doesn't cause pain there, and so we need to have screening for it. Rett syndrome's not cerebral palsy, but for cerebral palsy, there's now a very guaranteed and worked up pathway for how we screen for hip problems. And I normally recommend that we try and follow this for any young person with a movement disorder. Essentially what you're doing, and again, we'll circulate this, but if you've got ambulant children, you're recommending you do an X-ray at 2 years of age, and then you do it at 6 years of age, and then as long as there's no problems, you don't do it again until they've reached skeletal maturity at 16. If you're non-ambulant, it's really annual hip X-rays to make sure you're not missing. And we know from cerebral palsy, Rett syndrome is not cerebral palsy, so we need to be a bit careful how we extrapolate, but it's comparable for the movement, I think. If we monitor and intervene earlier, we do less invasive surgeries and we have better outcomes, and we don't need to do as many surgeries. So monitoring is really, really important. And the data at the bottom is just talking around the angles of contracture that are kind of red, amber, green in terms of when we need to make interventions and do things. Okay. Development and communication. I said this was the most important thing at the start there. So we need to document it at baseline, every time be looking at the gains and losses of development, and talking about how we're communicating. You know, the important thing is that there's a consistent approach. What you're doing at home is what's being done at the nursery and school, and there's a continuity of that there. It's very confusing if people are using different strategies in different environments there. We want to document and look at the fine motor skills, look at language and all these different issues there. Okay. Behaviour and sleep, and I'm coming towards the end there, so don't worry guys, I'll wrap it up quite quickly. But screening for sleep symptoms, screening for problems with anxiety and depression. Again, very, very aware that when I have an expert psychiatrist in the room, I'm not going to talk about anxiety management too much there. thinking about sensory processing difficulties, looking about pain. Now, one of my soapboxes and bugbears, a minor criteria for Rett syndrome is said to be a high pain threshold, okay? My big concern is I'm not convinced our young people have a high pain threshold. I think it's people just don't recognize when they're in pain and don't miss the signs there. So it worries me that that's a minor criteria because it suggests they don't have the experience of pain in the same way. I fundamentally don't agree with that, I'm afraid. And then we talk about sleep, looking at symptoms of sleep apnea. We don't recommend, or I personally wouldn't recommend, regular sleep studies, but screening for circumstances where it might be appropriate to do so. Okay. Going to screen for this because we're going to share these slides and I want to try to run to time as much as I can, but essentially making sure that we're screening. This is the most important thing, okay? I would hope that at least once or twice a year, a clinician involved in your child or young adult's care asks you guys how you're doing. Because if we don't help you look after yourselves, how on earth can we help you look after your young people, okay? And it's really, really important. And this is a message I really want to give for not just Rett syndrome, but any complex child there, you know? Screening and making sure the families are getting the support they need is a hugely important part of our job. Okay, so are you bored of hearing my voice yet? Has my daughter's prediction come true, okay? So as I'm sure you all know, this is an illustration from the original edition of Bleak House in 1866. And this was the first time the word boredom was used to describe a sense of experience rather than a person being boring. Now, I thought that was really interesting, but the fact that I did really explains why my daughter thought I was going to give a really boring talk today there. But yeah, boredom is there. So my last slide, and just to wrap up very quickly if it's okay. So what your local medical team might not know about Rett syndrome, that we need to communicate and we need to help you communicate. Okay? So Rett syndrome, it's not a neurodegenerative disorder. Okay? Really importantly. Still, few people out there who don't have that message, so we need to make sure that decline is not inevitable, we can make interventions and we can change the trajectory. Whilst epilepsy is very common, there are lots of episodes which look like seizures but aren't, and getting videos, having that open mind is really important. Awake breathing disturbances are very common. I think we need to be better at documenting it, better at discussing it, and better about thinking how we treat it. 12-lead ECG every month, as we've said. Individuals with Rett syndrome can gain skills once they've passed through regression. So you're not, when you're seeing them, when they're in the school environment, just holding them and stopping disability from progressing. You have to have an environment where there's the opportunity for them to thrive. A really important message for us. And I think my last point for this, the learning disability because of the communication problems is often overestimated. Okay. So that's the end of the talk for me today. I think probably opportunity in the panel to ask questions. But my plea is if anybody isn't registered on the Rett registry, please do so. Important way for us to keep track of you all as families, indicating when you're interested or keen to hear more about research. But I think I'll stop there if that's okay.